Bismillahirrahmanirrahim. Assalamu alaikum. I welcome all the audience from all around the world for today's webinar organized by Imamia Medics International Academic Council. I would like to introduce myself first. My name is Samreen Fatma and I am associated with IMI International Academic Council as Academic Coordinator. Today, I have my co-host, Dr. Kiran Ijaz, in this session. She is from US and has been associated with IMI International Academic Council for past 8 years. Welcome, Dr. Kiran.
Assalamu alaikum, everyone.
Walaikum salam. It has been a tradition of IMI International Academic Council to hold sessions every year for managing health on different global observances days. Like recently, World Tuberculosis Day has passed on 24th March. This session is one of the continuation of the series. Today, we have highly qualified clinical professionals here to discuss on the topic of tackling tuberculosis, treatment, and prevention strategies. This session will include tuberculosis awareness information for those who are suffering from the disease, as well as for those who are taking care of them. So we will begin this session with the name of Almighty Allah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والذي هو يطعمني ويسقين وإذا مرضت فهو يشفين والذي يميتني ثم يحين صدق الله العلي العظيم Surah Shu'ara verse 79 to 82. Now I would like to introduce my first speaker, Dr. Annie Kizilpush, who is an infectious disease and TB specialist. She is currently serving as Associate Professor of Medicine at University of Texas, Tyler in the USA. Welcome, Dr. Annie. Over to you.
Thank you so much. Assalamu alaikum, bismillah ar-Rahman ar-Rahim. Thank you so much to IMI for inviting me to speak at this webinar on tuberculosis awareness in honor of World TB Day. I'm going to start off the webinar by discussing some basic facts about tuberculosis, how big of a problem it is, and some of the more common risk factors for the disease. So first of all, what is tuberculosis? TB is a disease which in the majority of cases is caused by a germ called Mycobacterium tuberculosis. These germs are spread from person to person through the air by coughing. TB usually affects the lungs, but in about 15 to 20% of cases, other areas are affected, such as the lymph nodes, the brain, or any other part of the body. Next, how big of a problem is TB? TB is the world's leading infectious disease, and there are about 10.8 million people affected by it every year. It is also the 10th most common cause of death globally. There are 5 countries alone that make up more than half of all the cases. These countries are India, Indonesia, China, the Philippines, and Pakistan. This map over here you can see on the slide was taken from the Global TB Report published by the WHO in 2024. As you can see, the top 5 countries with over 1 million cases of TB annually are mostly concentrated in Southeast Asia. There is also a significant burden of disease in sub-Saharan Africa, which is driven by the HIV epidemic. Next. TB is a low incidence disease in the US, and during the COVID pandemic, the number of reported cases was at an all-time low. However, since then, the number of cases have been steadily increasing, and it was just released earlier this week that in 2024, there were over 10,000 cases, which is the most that have been reported in the last decade. Next. In the US, not all states are equal in terms of the number of TB cases that are reported. California, Texas, Florida, and New York alone make up about 60% of all the cases. This is because these are border states and have a higher number of foreign-born individuals, homeless populations, a higher prevalence of diabetes, along with other risk factors. Next. Next, I'm going to talk about what happens after an exposure to TB. In 70 to 90% of cases after an exposure, the TB germs do not cause an infection. In 10 to 30% of cases, the patient will develop an infection where the TB germs now live in the patient's body, and this is called latent TB infection. 90% of these patients will never go on to develop TB disease because their immune system is able to keep the infection under control. However, in 10% of individuals, they will go from latent TB infection to develop TB disease. Half will do so within the first 2 years after exposure, and the other half will do so at some point later in their lives when their immunity is down. Next. This slide describes in more detail the difference between latent TB infection or inactive TB and TB disease or active TB. Those with latent TB infection usually have less germs and do not have symptoms, whereas those with TB disease have more germs and usually have symptoms. Patients with latent TB infection are not contagious, whereas those who have TB disease can potentially spread their germs to others. Latent TB infection or inactive TB can only be detected by use of a test such as a TB skin test or a blood test, whereas those with TB disease do not necessarily have a positive skin test or blood test, but are rather diagnosed because of symptoms, an abnormal chest X-ray, or a positive sputum sample. The treatment for latent TB infection is given in order to prevent TB disease from developing in the future and is different from the treatment which is given to patients with TB disease in order to cure them and to prevent disability and death. Next. What are the classic symptoms of someone with active TB disease? These symptoms include having a chronic cough that lasts for 3 weeks or longer, coughing up blood or sputum, fatigue or a feeling of tiredness, fevers, chills, night sweats, loss of appetite, and unintentional weight loss. A patient may also have other symptoms depending on where the infection is in the body. Next. Now we know what a patient with TB classically presents with. That brings us to the risk factors for TB. We can divide risk factors into those that increase the likelihood of exposure and those that increase the chances of progressing from latent TB infection to TB disease. So what are the risk factors for exposure to TB? Being from or residing in a country which has a high incidence of TB disease puts a person at risk for exposure because of the likelihood of coming into contact with someone who has the disease. Those who live or work in a high-risk congregate setting, such as a long-term care facility, nursing home, or jail, and people who spend time in homeless shelters or use illicit drugs are at risk for exposure because of the crowding and the poor ventilation, which is often found in these settings. Healthcare workers are at risk, especially those who work in emergency rooms, ICUs, respiratory therapists, and pathologists, because they might be artificially aerosolizing TB germs in very large quantities while they're performing procedures or administering treatments. And then finally, people who are in contact with a person who has infectious TB disease are at risk for exposure. Next. We know that not every person who has been exposed to a patient with TB disease will get infected. Factors which determine if someone gets infected or not include, firstly, how contagious is the patient with TB who they were exposed to. For example, we know that those who have cavitary disease and are smear positive are more contagious than others. Other factors that determine whether an infection occurs or not include how susceptible is the contact in terms of their immunity. What is the duration of the exposure? And there's actually no safe exposure time that has been established. And then what was the proximity of that contact? As in, were they sharing a room together, or do they just meet outside at the bus stop, which would be considered a lower risk situation? Next. So we said that healthcare workers are one of the populations who are at higher risk for exposure. And the testing guidance for TB in the US is usually provided as part of the infection control plan of the healthcare system. The CDC does recommend screening all healthcare personnel for TB upon hire. Annual TB testing is not recommended anymore unless there is a known exposure or risk of ongoing transmission. Next. So when we talk about risk factors for TB, I did mention there are risk factors for exposure to TB, which we went over. But once a person has latent TB infection and the germs are living in the patient's body, what are the risk factors for progressing to TB disease? Next slide. So to sum it up in one slide, and this is my last slide, I thought I would show this table, which divides the risk factors for progression into high, moderate, slightly increased risk, and then low risk categories. High risk populations include those who have AIDS or HIV and are not on treatment, patients who've had a transplant and are taking medications that suppress their immune system, those who are on TNF alpha antagonists, which are also medications that suppress the immune system, patients who are on dialysis, and those who have cancer of the head and neck. In addition, if the exposure to TB occurred within the prior 2 years, or if someone has an abnormal chest X-ray with upper lobe scarring, that is considered to be a high risk for progression. Moderate risk factors include those who have received treatment with steroids, those with diabetes, and children who are under the age of 5. People who have a slightly increased risk compared to the general population include those who are malnourished, cigarette smokers, and then having an abnormal chest X-ray with a finding such as a granuloma, which is a spot in the lungs. Low-risk individuals are those who do not have any known risk factors for progressing from latent TB infection to TB disease. It is important to know which risk category a patient is in, because that way we can focus our attention on those who are at highest risk and treat them for latent TB infection before TB disease develops. And that is all I have. Thank you very much for your attention, and I will hand it off to Simreen to introduce the next speaker.
Thank you so much, Dr. Annie, for an insightful presentation. Now I would like to introduce our next guest speaker, Dr. Nafis Ahmed Khan. He is serving as Assistant Professor, Department of Respiratory Medicine at Jawaharlal Nehru Medical College, Aligarh Muslim University, India. He has been into the respiratory medicine specialty since last 15 years and has a vast experience of dealing patient with tuberculosis. Welcome, Dr. Nafis. Over to you.
Thank you, Samreen. Thank you for the nice introduction. And thank you, Yamia Medics International, for organizing such a webinar on an important disease. So thank you, Dr. Annie, for making me my presentation more easier, because you have explained what is latent tuberculosis and what is acute tuberculosis. So let's start the presentation that is regarding diagnosis and treatment strategy for tuberculosis. So first, let us discuss what are the options available to diagnose a tuberculosis. The first is most important thing is the medical history, and the second is family history, because we know that the exposure mainly it causes the spread of the disease. And the second is the TB skin test and IGRA, that is TB Gold, famously called, and CYTB. These three tests are mainly for the latent tuberculosis. Then chest X-ray and sputum examination. These two main tests are for the acute tuberculosis. Next slide. So first is how TB infection, that is for latent tuberculosis, what are the tests available? One we have discussed is TB skin test, that is famously called as Mantoux tuberculin skin test, and it is done by injecting purified protein derivative material under the skin, and the result will be out in 2 to 3 days in the form of reaction, in the form of the flare and induration. So US guideline that recommend TST for the children younger than 5-year age, and if the test is positive, that shows there is a TB germs in the body. As discussed earlier, that it's not the tuberculosis disease, it's the germs in the body. You will require additional testing such as X-ray to know that whether this is an active, it's not an active disease. And once positive, TB skin test may remain positive for a longer period, and test may be falsely negative in some patient like immunosuppressive, where immune system is not that strong. Next slide. So, and what are the blood tests? The important is this why blood test is important, because TST, that tuberculosis skin test, it requires two visits. One is to give the injection, and second is to call the patient after 24 to 48 hours to read the results. So it is not good for the homeless people or drug users, or it is not good for the prior BCG vaccination, because it is very common here also in all over the world to give BCG vaccination. So if patient is vaccinated, the result may be falsely positive in skin test. So for that, blood tests are required. So the first one is interferon gamma releasing assay, that is quantiferon gold or TB gold. And second is CYTB. These are the latest development. And these tests are valid even if someone has received the BCG vaccination. So if it is unaffected with BCG vaccination prior. Next slide. So, that is the latent tuberculosis for a skin test or blood test. But if it is acute tuberculosis, what are the important things? As discussed by Dr. Annie, that what are the clinical features? One, we assess the clinical features. If patient is presenting with fever, cough, expectoration, we advise the sputum examination if patient is producing phlegm. And the important thing is we need to test the sputum for consecutive 3 samples, at least 8 to 24 hour apart, and one sample should be the morning sample. And this specimen should be collected in an airborne infection isolation room, because there is a chance of a spread of infection if somebody is expectorating, and either in a sputum collection booth or any other isolated or well ventilated area. Next slide. So if suppose that a patient who has been diagnosed at latent tuberculosis, like TST is positive, or blood test for the latent tuberculosis are positive. So what are the options we have? The first thing we need to do, that we need to rule out the acute tuberculosis. And if it is ruled out, we need to give some treatment. So this treatment was given in the low epidemic areas, low endemic areas like US, as discussed by Dr. Annie. But in India, it was not feasible. Or like in countries where there are more cases, it was not feasible. But now, since last 1 year here in India also, we are treating these latent tuberculosis. And these are the 3 regimen, that 3 months of once weekly isoniazid plus rifampicin, that is 3 HP. That is the most used regimen. 4 months of daily rifampicin and 3 months of daily isoniazid plus rifampicin. It is dangerous to stop TB medication or not take it full course, as it may cause the resistance to develop. And acute TB must be excluded before initiating the treatment, because it may cause the resistant MDR to be developed. Next slide. And for the acute tuberculosis, treatment for acute tuberculosis, that they can take 6 to 9 months depending on the treatment plan. And the treatment plan is give these medication, which includes ethambutol, isoniazid, rifampicin, rifampicin, and pyrazinamide. So the regimen, according to WHO, it's 2 months of HRZE. That is isoniazid, rifampicin, pyrazinamide, and ethambutol. That is called intensive phase, first 2 months. And the next 4 months with rifampicin, isoniazid, and ethambutol. There is no pyrazinamide in the continuation phase in the last 4 months. So total 6 months course, first 2 months with 4 drugs, and next 4 months with 3 drugs. Next. So one important thing, why we are not able to contain this disease, why we are not able to control this disease, is development of the multi-drug resistant tuberculosis. So multi-drug resistance means, as we have discussed, all the medicines out of this rifampicin and isoniazid, these two are the main medicines to fight with the tuberculosis. So the important thing about Mycobacterium tuberculosis is they create a resistance in themselves. So if a patient is showing the mycobacterium which is resistant to INH and rifampicin, two most important drugs, that is labeled as multi-drug resistant, MDR. And what is XDR means, the option for the treating MDR is mainly levofloxacin, linezolid, like all these second category medicines for MDR. So if suppose that a mycobacterium tuberculosis, which is in addition to rifampicin and isoniazid, resistant to levofloxacin or linezolid and bedaquiline, that are the main group 1 disease, these patients are called extensive drug resistant tuberculosis. And drug resistant TB is more common in the people who don't take all these medicines as directed, develop TB disease again after taking TB medicine in the past, and are exposed to someone with a drug-resistant tuberculosis. So if we can see all the three causes, they are all preventable. So if we can discuss and we can make plan that the patient take the medicine completely and he is not exposed to any MDR TB patient, we can decrease the at least communication of this disease. Next slide. So for the diagnostic method of MDR tuberculosis, it's not just the sputum stain. So for the active tuberculosis, it was sputum staining for the Mycobacterium tuberculosis. But here we are having nucleic acid amplification test that is called CB-NAT or TrueNAT or gene expert test. The results are available in 12 to 24 hours. And line probe assay and the sputum for FB culture and sensitivity. So in the past, this sputum for FB culture and sensitivity was the most important test and only available test at that time. Although it is a gold standard, but it takes at least 2 to 4 weeks for the results to come. So nowadays, this nucleic acid amplification test here in India or in most of the part of the world, they are using CB-NAT test so that within 12 to 24 hours, we know that this patient is having any resistant tuberculosis or the microbacterium of this patient is sensitive. Next slide. So if you talk about the prevalence of tuberculosis in India, so according to Global TB report in 2023, we can see that India accounts for around 27% of the global TB cases, the highest burden of in the world. And in 2022, India reported an estimate of 2.82 million new TB cases, that is 199 cases per lakh population. And the death is around 23 deaths per lakh population. So this is quite high if we compared other part of the world. Drug-resistant TB cases, 2.5% in new TB cases and 13% in previously treated TB cases. But the good thing is, if you can see the second slide on the right side, the India leads in TB cases decline. If we talk about 2015, it was 237 cases per lakh, the incidence was. But here now it's 195 per lakh. So it's about 17% of the decline. So that is one good thing, means because of the government policies and because the government are providing all the medicines free to the patient. There is no cost burden for the patient. So that may be the effect, and most probably in future will be further able to decline this disease. Next slide. And one more public health measure that is recently has been started in India. Like the previous thesis were saying that in high endemic cases, you should not treat the prophylactic treatment or, TB infection, latent TB, you should not treat that. But since last 1 year, the government program has been provided these medicines for the prophylactic treatment for the TB infection cases, latent tuberculosis. So it is administered to all the close contact, which includes household contact of the pulmonary TB bacteriologically confirmed cases, irrespective of ages. And TPT for the ruling of, so tuberculosis preventive treatment after ruling out active TB or patient living with HIV, we need to give each and every patient. Household contact, if it is less than 5 years. Household contact, if it is more than 5 years, then we need to see the TBI positive, like blood test or skin test is positive and active TB is ruled out. And in other high risk group, as discussed by Dr. Annie, that all these transplanted patient or diabetic patient, malignancy patient or chronic kidney disease patient, in that also, if it is TBI is positive, we need to treat these patients as a latent tuberculosis. Next slide. So in Indian population, like very recently, in last month only, we have started this shorter regimen of 4 to 6 months for the MDR. That is BPAL regimen, one of the famous. WHO have recently approved that to use all over the world, which is bedaquiline, protonamide, linezolid, and moxifloxacin. So the important thing was for MDR was there are many drugs, and the regimen is for at least 9 to 11 months for shorter regime and 18 months for the longer regime. And those medicines, they were having a lot of side effects. So that also causing these patients to be dropped out from the treatment because of either side effect or because of longer duration of the treatment. So this newer BPAL regimen is hope for the patients. They will be treated in 4 to 6 months if it works, because it has proven to be a safe, more effective, and quick treatment option than the previous multi-drug resistant treatment. Next slide. I think that's over. Okay, thank you. I'm here. I'm available for any question if anybody ask. Over to Samri.
Yeah. Thank you so much, Dr. Nafis, for a comprehensive and educational presentation. Now, I would like to invite my last speaker, Dr. Shaila Naqvi, who is a pediatric infectious disease specialist. She has worked with children with complex infections, including HIV and tuberculosis. Her experience spans USA and Pakistan. She has been on the faculty of St. Louis University, Khan University, and State University of New York, USA. She has served as specialist with New York City Department of Health Bureau of Tuberculosis Control. And in addition to her professional career, she also writes poetry and short stories in Urdu. I welcome Dr. Shaila. Over to you, ma'am.
Dr. Shaila, we can't hear you.
Assalamu alaikum, ladies and gentlemen.
Walaikum
You
assalam.
have just heard a very comprehensive review of tuberculosis. The facts and figures were displayed so clearly in the graphs and the tables shared by the two speakers. I will limit my remarks to only tuberculosis in children. As you've heard, it's an infectious disease. 30% of the world population is carrying the germs of this disease in their lungs. And this is causing the death of about 1 million people every year. Why is this happening is the question. When we have medications to treat it, we know about preventive therapy to stop it from progression, from infection to infectious, contagious disease, I should say. And why is it that we cannot prevent spread of the disease to vulnerable children? When you look at it, there's a lack of worldwide commitment to control of the disease. As Dr. Nafis said, and I'm proud to hear him say that India brought down the rate of tuberculosis, they devoted $1.8 billion a year to control of tuberculosis program. So therefore, a good investment in worldwide healthcare is the only way to bring this disease in control. Before the Second World War, there was no treatment for tuberculosis. It used to affect all social classes. Rich people, poets, writers, politicians, they're all in history having tuberculosis. There's poetry written about women with their pink cheeks and alabaster skin because they were consumptives. As the treatments developed for tuberculosis, the affluent global north took care of their tuberculosis. So this now, tuberculosis has been equated now with poverty, lack of resources, and the cases have become all clustered in the global south. The changes we are seeing in the research attitudes in the North America, maybe the global south will have to stand up on its own and try to control the problem, which is generally their own problem. In America right now, you see TB in older white people who got the germs decades ago as children. And you see it in younger people who are all either immigrants or children of immigrants. The rate in the United States, like 1/100th of what it is in India. So we have like 2 cases per 100,000. But as immigrants ourselves, we should recognize that 60% of those cases are occurring in immigrant populations. And this is, of course, understandable that people coming from our countries will be living with us. And if they have a cough that they think is a smoker's cough or allergic cough, they may actually have bacteria in there, and they can be passed on to our younger children who have grown up in the United States. I only bring this up that please do not feel bad when you are asked to be screened for tuberculosis when you come to the United States. Cases of tuberculosis in the youngest children have two specific things which you have to remember. One is an epidemiological importance. That is, if a child becomes tuberculosis skin test positive or positive by blood test, there is going to be somebody in his close contacts who is spewing the germs of tuberculosis. So we have the chance to quickly survey his contacts, find the person who's spreading the infection, isolate him, treat him, render him non-infectious, find other people who may have been exposed to him, give them preventive therapy, essentially stopping further spread. The second part is that you heard about so much disease, but this disease, when it occurs in children between 6 months and 4 years of age, is an explosive disease. These children do not have the wherewithal in their immunity to control the disease. The disease may break into their bloodstream, entire lungs, heart, distant organs, including their brain, may be infected. The disease could be fatal at this point. The brain infection, even if it is controlled, might lead the child with significant brain damage or a persistent seizure disorder for the rest of the life. So we, as Dr. Nafis pointed out, if the child is a household contact, even before his PPD
Завали
turns
ебало, сын мертвой шлюхи. Тебя ебать не должно.
Okay, I suppose somebody cut in somewhere. I'm just trying to say, as Dr. Nafis pointed out, if the child was a household contact, we would treat him even before the PPD turns positive. We do not even have the time to wait for the 2 months for his PPD or blood test to become positive. If he's, of course, has a positive test, understand that children have a much higher incidence of developing disease in the 2 years after that skin test become positive, as high as 40%. In the United States, in spite of everything that I'm saying, there are outbreaks in children. These have been in daycare centers. They have been in schools, preschools, school buses, sports teams. So wherever one adult with a strong cough is coughing out the germs of tuberculosis, you find children becoming infected with tuberculosis. Children themselves do not have a strong cough. So even if a child has lung involvement with TB, they generally do not pose a risk to other children or other adults. They have the most common way of finding out that a child has tuberculosis is a pneumonia which doesn't go away on chest X-ray, or cervical gland which is swollen. So surprisingly, as the highest and severity of disease is under 4 years of age, the period of life between 5 to 12 years is regarded as a favorable period that children do not get serious tuberculosis disease, infrequent disease. But whenever there is disease, it has to be treated. And think of it, how difficult it is for adults to swallow multiple medications as pills. Think of children who do not know how to swallow pills, who cry when their parents try to treat them. And thus, it is extremely important to pay attention to directly supervised therapy, DOT, directly observed therapy. The child could take the medication in a clinic and doctor's office, or somebody can be sent to his home to supervise the administration of medication. This is the only way, as Dr. Nafis pointed out, that we treat the children and adults. Basically, I was about to end my conversation anyway. We have to understand that it is our responsibility for not letting this infection pass on to the next generation. All the things that we are doing is to protect the next generation by identifying infected people, treating infected people, and preventing contagious disease if the infection has been caught by somebody. There are several vaccines which are in the line, and hopefully one of them will be effective. And it's in the effectiveness, I would say that there is a model for us in hepatitis B that we started. It used to pass from one generation to the next generation in a vertical manner. We started immunizing children at birth, and we stopped transmission to the next generation in large part. This is my dream for tuberculosis, that we will have a vaccine with which we will stop transmission to the next generation. Thank you very much for your time.
Thank you so much, Dr. Shahla, for your insightful presentation. Now I would proceed to question and answer session, which will be led by Dr. Kiran. Over to you, Ms. Kiran.
Thank you so much. I'm sorry about the cyber attack. We have taken care of it, and no more people will be admitted to the group over here right now. And I've closed the from incoming. So thank you, Samreen, and our presenters for sharing the details of identifying and treatment of active tuberculosis as well as latent tuberculosis. Now we'll open the floor for Q&A. What will happen is this: you can either use the raise your hand option that is under the reactions option at the bottom of the screen, and otherwise you can actually unmute yourself and ask the question. While people are typing in, I would like to request the audience not to share any personal information like your age, because this is a general forum. So we have to keep things anonymous.
Dr. Kiran, I am Professor Bukhari. Can I ask a question?
Yes, please. Please go ahead.
Oh, thank you so much. First of all, I am highly obliged that you invited us for this session. My one question to Dr. Shahla Naqvi, because I'm in Pakistan, there was a walk last month of the tuberculosis, and we are afraid that Pakistan is also becoming the first top country in the world who is spreading in the tuberculosis. My very important questions, one to the Dr. Shahla Naqvi. Do you think the children, it is a vertical transmission? If the mother is suffering from tuberculosis and she becomes pregnant, and the baby will be tuberculosis, or it is the secondary transmission with the contact in the family or in the children or in the school?
There are cases in which even the uterus gets infected, but the vast majority is the child is in the mother's arms and mother has active TB and is coughing. So this is a good chance to treat the mother and use a mask and good hand washing to try to prevent as much transmission as possible.
And another question to the Dr. Nafis, do you think the after COVID has become very important factor in spreading and getting more tuberculosis like in India and Pakistan?
Actually, what COVID did to us is to make us understand what is airborne diseases are and how lethal they can be. Before the COVID, if we say to the patient, you use the mask because this disease is going to spread, they were not understanding properly. But after COVID, since last person of the country, in whichever country you are, the last person of the country understood the importance of barrier, this thing. So the using mask and using mask properly, this COVID have taught us. And I think that knowledge only we are utilizing to prevent from all the airborne diseases. So I think because of COVID, this learning we have received a lot. But since COVID has done a lot of damage to the lung, so they are immunosuppressive, a lot of steroid uses. So maybe there is an increased incidence. I don't know exactly. There is not much data, but maybe there is slight increase in tuberculosis because of damaged lung and steroid used.
Yes, thank you, Dr. Nafis. I have read so much literature, and then in the literature there was mentioned that COVID has destroyed the lungs, and this can lead to the tuberculosis, and that is why the more tuberculosis coming in the children. And
Yes.
similar question to you as a pathologist, I ask, what is the role of genetic testing in the diagnosis of tuberculosis? And
There are the tests which are available. They are all molecular based tests. It's not genetically designed. The genetics is important where we need to see the mutation of the genes. So for the Mycobacterium tuberculosis, what all are the mutation? Because of those mutation only we are able to treat the diseases. Like for the medicines, like we know the CAT G gene or INHA gene for rifampicin, then RPO for the for isoniazid and RPO for rifampicin. So these genetic testing is important from the medicine point of view for the treating these resistant cases, these mutations.
thank you so much.
Thank you, the panel, for discussing good key points. The next question that we have is, could you review how to deal with a person in the hospital who is a suspected person for latent tuberculosis and or another person who is active tuberculosis in terms of isolation and duration?
Uh, Pardon, I couldn't understand the
So the
question.
first question is, these are two questions. So number one, the first question is how to deal with a person who is hospitalized and we know that a person is suspected of latent tuberculosis. So how much
Okay.
in terms of isolation, what level of isolation should be there and for how long for
Okay.
latent
So,
tuberculosis?
if we are suspecting a latent tuberculosis, first of all, this patient is not infectious to others. The only thing is why we want to know about the latent tuberculosis is this: there is a risk for that patient only. Because if suppose that patient is sick and because of some kidney disease or because of some other immune suppressive diseases, that patient is on risk of traveling from latent to acute tuberculosis. So we need to do these tests like skin test or blood test to make sure that this patient is not having any latent tuberculosis. And if it is there, he need to see that whether this is active or it's only latent. X-ray is normal, sputum is not showing any mycobacterium tuberculosis, and straight away we can put that patient on the prophylactic treatment. And if suppose that there is a active tuberculosis, we need to treat them properly, like we keep the patient in isolation using proper mask and start the proper treatment of tuberculosis. So these two are different things. If we are suspecting latent tuberculosis, means this patient is not going to spread the infection, and we need to treat that infection as a prophylactic treatment if it is positive as latent tuberculosis.
Perfect. So how long is the isolation for the active tuberculosis patient?
So, literature says that when you start the tuberculosis treatment, within 2 to 4 weeks, that patient will be sputum negative. So, generally, the isolation is over once that patient is showing from sputum positive to sputum negative. But still, if suppose that patient is not expectorating much, we can say that after 4 weeks, we can stop the isolation. Nowadays, there is no strict isolation. If patient is using properly the mask and using all these barrier method, that patient after 2 weeks is enough to move around.
I see. Perfect. Perfect. Our next question is for Dr. Kazalbakhsh. Would you consider some patients who are at high risk for non-compliance for observed therapy?
Right. So, you mean if they have latent TB infection? Usually observed therapy, at least in the US, is for the weekly regimen, which is INH and rifapentine. But the other treatment regimens, which are for latent TB infection or inactive TB, are done self-administered. At least over here. For TB disease, if a patient is not taking their treatment the way they're supposed to, we actually, so for the state of Texas, our hospital actually court orders them. So the patients are ordered by court to complete their therapy at our hospital. And so they figure out a way. Either they treat them in jail over here. If patients are, in some other states, they deal with, I think each state deals with their patients who are not adherent in different ways. But in Texas, they are basically hospitalized against their will so that they can finish their treatment and not pose a, risk to the public.
Great.
New York has about similar attitude. We have a very good directly observed therapy program where people go and administer the medication supervised administration of medication at workplaces, at homes, at times which are convenient for the patient. They do it privately so that they are not stigmatized in their workplaces also.
And they
Here
also
in
have
India,
video DOT now. I think a lot of places, a lot of health departments provide video directly observed therapy so that the patients don't even have to go necessarily or meet with a healthcare, staff every day. So that makes it easier as well. Sorry, Dr. Khan, you were saying something.
yeah, here in India also, the government program are all directly observed therapy. So each and every patient is being monitored for the treatment, whether he is taking the treatment or not. We are following the patient. Each and every patient is being followed up, whether this patient is improving or not. If any treatment failure or any dropout from the treatment, that patient is being pointed out. So every patient is registered at one platform in all over the India. There is an ID called Nikshay ID. So that ID, you can any part of the India if patient is traveling, everybody will be knowing at the where at the office where he is being registered. So that is one good thing. We are not seeing the patient drop out from the treatment, because that was one of the major reason for the treatment failure and MDR.
Great. The next question is with regards to vaccines, the BCG vaccine that is given in the India and Pakistan. What about like US? What is there any new vaccine coming up? Or can you guys talk about that a little, please?
There are, I think, about 5 vaccines which are in trial, and we can keep hoping that one of them will be the vaccine. The BCG vaccine has never been seen as an adequate vaccine, but when given to the youngest children, generally soon after birth, it raises their immunity to the point that they are the disease risk of overwhelming disease becomes less. And we have the time to treat them if they catch infection. And so there is, we totally disregard the, 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 the administration of this vaccine when we are treating children in the United States. I'm sorry, I'm saying that even in my own experience in Pakistan, I found that we would give the BCG vaccine, the children would have a positive PPD, which became negative by 2 years of age.
Okay, that's good. That's really nice. And what about gender differences? Are women more prone to get tuberculosis, or it's equal? What about that?
According to literature, men are more likely to have tuberculosis than women, and under 15 years of age in children, there's no difference between boys and girls.
Perfect. Our next question.
This is Dr. Kiran. This is not due to gender difference. This is due to as the men's work more in the society and they go more outside, like in Pakistan, while the females are more limited to their homes inside. That is why there is a little difference. Otherwise, there is no difference of infection in mycobacterium tuberculosis infection in males and females.
You mean the level of exposure? Okay. That's a good insight. So, would the panelists comment on that, or?
So I actually did hear last year, and this is a very new area of research, but I think they're actually doing some more studies now related to gender differences. And I know traditionally that's the way it's been thought, that men, because they work and they go out more, especially in developing countries, they're at higher risk for exposure.
Yes.
But there's also some genetic differences that are being looked into now. And I don't have all the details on that, but that's a really upcoming area for research.
Okay, great. The next question we have is it necessary to have the TB blood test, or only the skin test is enough to check for active tuberculosis?
So the TB blood tests, they are more sensitive as compared to the skin test. And as we have discussed earlier, that in India and Pakistan, there are children who are being vaccinated with BCG. So if they are vaccinated with BCG, some of the people, they will come up with positive skin test. So to rule out those things, these blood tests, they are more sensitive and more specific, but as well as they are more cost, like they're not cost effective as compared to TST. So in a country like us, we are more dependent on skin test, because in a government program you cannot add these type of costly medicines. So I think till now we are using skin test as a group, but yes, we prescribe blood test for some of the people because it is more sensitive.
Right. And then the next question is, someone in my close contact has latent tuberculosis but refused to take medicine. Am I at risk of getting infected?
As Dr. Nafis has said before,
Not
people with latent TB are not contagious and do not form a risk to other people.
And
But
if he's not ready to take at least he should get it checked up whether this is active tuberculosis. At least he should get it ruled out of active tuberculosis. If it is not there, the people who are living surrounding to that person is not at risk.
Basically, they get labeled latent
I
when the
think
chest X-ray is negative, right?
Yes. So
but
basically,
this
they are feared about pulmonary coughs only, because that is more contagious. If they are open cases, they are positive cases, they are more infectious.
Can I add one thing, Dr. Nafis?
Yeah,
yes,
yes, sir.
go ahead.
I am Professor Shamim, Head of Department Respiratory Medicine at JNMC, IMI Aligarh.
Welcome to the club.
Most of the cases of latent tuberculosis, they are actually subclinical infections. So these patients, they form a bulk of transforming into active tuberculosis. Ideally, if you find a latent tuberculosis, they should get checked, as Nafis said. They should be checked, investigated, and they should start the treatment.
Yes.
Okay, perfect. Yes, I think the person who's writing this question, the patient who has the latent tuberculosis, they were suggested to take medicine, but they're refusing. So they're trying to see for their own health, because they live with the same, like, so they're trying to see like if they can get tuberculosis from that latent TB person.
So I think basically what would have to be done in that situation is just for them, the person who's living with the patient with latent TB infection should just be aware of the symptoms that a patient might have with TB disease. So if they have active disease, right? So if they start coughing or if they have fevers, just know what to look out for. And then obviously they would need to get evaluated and all of that. But if they have just latent TB infection, they're not going to be they won't infect the household contact.
Yeah, definitely.
Or have a one-on-one conversation. Please take the medicine.
Exactly.
And basically, it depends upon when did the TB test convert. If it has converted recently within the last 2 years, this person is probably better off being treated. If it was a positive for the last 10 years, he probably has very low chance of becoming infectious.
Interesting. Okay, that's great. Good. Last question.
Can I?
You had skin testing?
Sorry, we didn't, Zubaida, we didn't get, we can't hear you. Can you please repeat your question?
Yes.
Dr.
My name is Zubeda. I am an immigrant from India. I was being immunized in India when I was very young for the tuberculosis. But every year, I work in the hospital, and every year we are supposed to have the tuberculosis test. And whenever I get the test, it becomes like a positive for me. But recently, about 10 years back, the government says that no, Department of Health, I have to go and get the letter from them that I cannot be immunized again because that is causing me a health hazard. So,
Yes. You poor thing. No,
uh-huh.
if the tuberculosis test is positive,
Yes.
and the chest X-ray is negative, we
Yes.
do not make people have the test over and over again, because obviously you will have a reaction every time and suffer.
Yes. So I don't have any possibilities of getting tuberculosis.
Well, you can't say that.
Uh-huh.
God willing, you'll be fine. But something intercurrent, developing diabetes, developing kidney problems, even having an HIV or other virus infection, which lowers your immunity, could. So whenever we are in healthcare and we have a positive PPD, it's up to us to get routine chest X-rays every other year, or whenever there are any pulmonary symptoms, to make sure that we are not uh, posing a danger to our patient.
Okay, thank you very much. Thanks a lot.
That's great. Professor Shamim, you were saying something. Sorry.
I was asking Dr. Shaila that she was advising actually repeated testing to rule out the latent tuberculosis.
I'm sorry, I didn't understand the question.
No, you said na ki if the conversion is latest, I mean within 2 years, then the chances of active tuberculosis is high.
Yes, sir. That is,
So-
preventive therapy is much more important for people who have recent conversion versus those who have carried a positive TB test for a long time. We used to have a cutoff for 30 years. You had positive PPD under 30, you got preventive therapy, and if you got it, so the idea was the same, that have you recently encountered the germs?
Okay, great. I think with that it's 12:30, and we would like to close the Q&A session. Thank you everyone for a really good discussion, and all these questions that are always lingering in the mind and nobody's asking because of the trauma that goes along with this, having a tuberculosis in the family or something. So this was really good to discuss everything. For the future, please keep a lookout for messages from IMI. We have upcoming health awareness sessions similar to these that we will be sharing. It's usually on a Saturday morning, like around 11:30 Eastern time. And we also have a newsletter that is for tuberculosis this month. And I'll ask Samreen to share it in the chat as well. And you can see the tiny URL link on the screen over here as well. Over to you, Samreen.
Thank you so much, Dr. Kiran, for such a wonderful question answer session. It was very informative. And I thank you all the audience for listening patiently. And I thank you all the speakers who have given such an informative session for IMI on the platform of IMI Academic Council. Inshallah, we'll be having more such sessions from the platform of IMI Academic Council, and we'll be sharing you the latest information with the flyers. Thank you so much.
Thank you. Thank you.
Thank you, everyone.
Thank you so much. Thank you so
Thank
much.
you.
Thank you, Dr. Nafis.
Thank you so much.
Thank you, ma'am.
Thank you to
Dr.
the
Stella.
speaker. Thank you.
Yeah, thank you, speakers. Special.
Thank you so much.
Thank you, sir. Thank you.